Good afternoon, ladies and gentlemen. My name is Nirav Shah, and I'm the director of the State of Maine Center for Disease Control. I thank everyone for tuning in to hear the latest updates on the COVID-19 situation across the state of Maine for today, Wednesday, June 3rd, 2020. We begin today's update on an unfortunate and sad note. Maine CDC is reporting another individual who has passed away. This individual was a man in his 70s in Knox County. This individual's passing marks the first death in Knox County and also marks the 95th death associated with COVID-19 across the state of Maine. All of us at the state of Maine offer our deepest condolences to the family of this individual during this time of their deep grief. Overall, Maine CDC is now reporting 2,418 cases of COVID-19 across the state. Those 2,418 cases include 2,152 that have been confirmed and 266 that are probable. Of those cases, 587 are among healthcare workers. At present in the state, 40 individuals are currently hospitalized, 14 of them in ICU beds, and 10 of them on ventilators. Statewide, 1,699 have recovered since our activation around COVID-19. I'd like next to provide an update on a new outbreak that Maine CDC is investigating. Just yesterday, we opened an investigation into an outbreak that could be potentially associated with the Eldridge lumber facility in York County. There have been a total of 13 individuals thus far who are associated with that facility who have been diagnosed as positive for COVID-19. Our investigation is underway, and as with any type of workplace facility outbreak, one of our key questions is whether the work site was the location of where transmission occurred, or whether, independent of the work site, a number of individuals contracted COVID-19 and happened to work at the same location together. Again, our investigation, including recommending universal testing, is underway, and as updates evolve, we'll certainly be able to provide them for everyone. I'd also like to provide a brief update on some of the open outbreaks in which Maine CDC has been involved. At the Barron Center, there remain a total of 4 cases, 1 among a resident and 3 among staff members. And with respect to outbreaks at the Procter & Gamble facility in Auburn, there remain a total of 7 cases. Our investigation there is underway, including starting to receive results of universal testing that was done at that facility. Again, as we receive more results from the universal testing, we'll make sure we update and report those for everybody. I'd also like to provide an update, as we often do on Wednesdays, on where things stand with respect to testing statewide. Let's start with the latest on positivity rates. Cumulatively, for all the tests that have been done across the state of Maine, our positivity rate for the molecular or PCR-based tests that give us an indication of the active state of infections, that positivity rate has dipped below 5% to 4.97% now. This represents a total number of tests that have been done of 59,443. Breaking that number down even further, of that 59,000, 55,051, that's 55051, are tests that have been done by PCR, and 4,392 are tests that have been done by antibody testing. When you add those up and just take a look at the positives, our cumulative positivity rate is now just a hair under 5%, 4.97 to be exact. I'd like to put that number into context. Nationally, the cumulative positivity rate has been about 10%, or double what we've seen in Maine. Just taking a look at other states in the Northeast, the positivity rate in Massachusetts is still hovering at around 17% cumulatively, about 9% in Rhode Island, 6% in New Hampshire, and about 3% in Vermont. That is to say nothing of states whose outbreaks have been even more significant, such as New York, where the positivity rate is 17%, or New Jersey, where it remains at 20%, or Connecticut, which is at 16%. We've talked for several weeks now about the importance of this positivity rate. It tells us, among other things, whether the net that we are casting with our testing is broad enough. According to many authorities, including the World Health Organization, as well as the US CDC, states should be looking to get the positivity rate as low as possible. Some say below 10%, some say below 5%. In either event, we're there. But we still have more to go. I've talked about one of our personal goals of having the most updated current positivity rate as opposed to the cumulative positivity rate at down to 2%. The other thing that the positivity rate gives us more insight into is whether we are able to reach out and detect asymptomatic individuals. As we've talked about quite at length at these meetings, a lot of the reason that COVID-19 poses such a challenge is that individuals can have the disease and transmit it even before they start showing any symptoms. The lower that positivity level is, the greater confidence that we have that we're picking up not just folks who have symptoms, but also folks who don't have symptoms yet, so we can get them into safe spaces so they don't potentially infect others. Driving that positivity rate as low as possible is one of our goals. One of the ways that we expand that we drive that positivity rate lower is by conducting more tests. So I'd like to provide an update on just what has transpired in terms of testing in the past week. Just in the past week in Maine, the volume of tests that have been done has jumped about 20%. I'll break those down by the type of test. Overall, just in the past week, there were about 9,844 tests that were conducted statewide, an increase of 19.8% compared to the week before. Breaking that down even further, of those tests, 9,090 were PCR tests, and 754 were antibody tests. Again, we've still got more work to do ahead of us. But if we take a look at what we saw in those tests that were just done in the past week, we see that we are heading in the right direction. So I'd like to talk about what we've learned just from the tests that have been done in the past 7 days alone. As I mentioned, statewide, and sorry, for this piece, I'm just going to be talking about the PCR tests. Because as we're talking about what we've learned and seen in the outbreak, I want to make sure we're just looking at the type of test that gives us an accurate estimate of the current outbreak, and that is the PCR test. So looking at that PCR test a little bit more closely, I mentioned a moment ago that there have been 9,090 tests that were done with the PCR method in the past week. Of those tests, 319 were positive, which gives us what's called a point positivity rate of 3.5%. This is that number that I'd like to drive down as low as possible. We've made significant strides just in the past week. 1 week ago today, that number was 4.1%. We've reduced it even further just in the past 7 days, going from 4.1% to 3.5%, just based on the tests that were done in the past week alone. Again, we've got more work ahead of us, but that 0.6 percentage point drop just in the past week tells our team that we are headed in the right direction when it comes to testing, the volume of testing, and the fact that we are catching as many potential positives as we can. Before I turn things, I'd like to next provide a brief update on some of our public health emergency preparedness activities. The first is around our work to ship out as many swabs and kits of viral transport media to healthcare providers across the state. Our public health emergency preparedness team has continued to work around the clock to push out as many of those swabs and transport kits as we can. And thus far, we have pushed out 27,000 swabs to healthcare providers across the state and about 25,000 vials of viral transport media and saline to healthcare providers across the state. This is a key piece of our overall testing strategy. One piece of it entails making sure that we've got the capacity to do the tests at our laboratory in Augusta and at other laboratories across the state. The tests don't just run themselves. We have to have the swabs and the transport media to do the test and safely send it to a laboratory. That's why this effort to push out as many swabs and transport media has been so vital. Thus far, we've shipped out over 120 orders, and we are not taking our foot off the gas right now. For this next phase, where testing has been critical, delivering as many swabs and viral transport media is more important now than it ever has been. But we're continuing, for example, with our orders of PPE. Just today, 36 orders of PPE will be distributed to healthcare facilities across the state, with our continued focus on congregate care settings, first responders, and hospitals, who we are proud to be able to help across the state. I'd also like to provide an update on our distribution of a drug called remdesivir. A few days ago, I mentioned that the state of Maine would be receiving its latest shipment. Yesterday, about this time, we did. We received 4 cases of remdesivir. Remdesivir is a drug that, among other things, is used for the treatment, can be used at the physician's discretion in the treatment of COVID-19. The shipment that we received yesterday required particular care and packaging. And so we were ready when the shipment arrived from FEMA because it had to be kept cold during transport. As soon as it arrived at our warehouse, within about an hour and a half, we had kept that cold transport intact and had it shipped to healthcare facilities across the state. And it was the very last shipment of remdesivir was delivered at 1:46 p.m. yesterday afternoon to healthcare facilities across the state. We've been notified by our partners in the federal government that more shipments will be on the way throughout the month of June. As we receive more data on that, I'll make sure and keep everyone updated. Finally, a quick update on our overall vital medical statistics that we track all the time. In terms of the number of ICU beds, there are a total of 394 across the state, 157 of which are available. There are 315 ventilators across the state, 239 of which are available, and there remain 441 alternative ventilators available. Before I turn things over to our colleagues in the media, I wanted to end today with a commemoration and a biographical note. Yesterday, I mentioned a woman in her hundreds who passed away with COVID-19. I even went so far as to speculate that she may have been born during the last global pandemic of 1920, or during that global pandemic. Her family actually graciously reached out to us to share even more information about this remarkable Maine woman. And as we stop to remember that every single number that I share represents a person, I want to take a minute today to honor this individual and provide a bit more information about who she was. This is an individual who entered the world during that last pandemic that we've now learned so much about. Her mother was so sick when she was born that she had to live with her aunt for some time after her own birth. This individual grew up to become a nurse, and shortly after completing her nursing education, she decided that she wanted to see the world. So during World War II, she decided to enlist in the Army as a nurse. Among other places around the globe, it turns out she served in India, which she loved. She was actually one of 6 of her siblings, all of her siblings. She was but one of 6 who served during World War II. Sadly, one of her siblings did not return. After the war, she held leadership positions as a nurse across the state of Maine. For a while, she was the head of nurses at the Maine Ear and Eye Infirmary. And it turns out she was also the head of nurses for the state of Maine, right here in Augusta. Later in her life, she married a potato farmer and lived in Aroostook County for many years, where she continued nursing late into her life. Eventually, she sold the log cabin in which she and her family lived in northern Maine to move to southern Maine to care for her sister. That sister was her roommate when she passed away. I wanted to take a moment to share her story as a reminder to us that each and every statistic is a person, and that behind each and every one of those statistics is a story. And so on behalf of all of us, I'd like to thank this individual for her service to the state of Maine, and thank her family for sharing her story with us and allowing me to share it with everyone here today. With that, I'd like to turn things over to our colleagues in the media. And today's first question goes to Megan from WMTW.
Thank you, Dr. Shah. My question surrounds new cases involving healthcare workers. I understand the point positivity rate has gone down from week to week. So it was a week ago, it was about 4.1%, and now we're looking at about 3.5%. But I looked at the number of cases among healthcare workers, and in that same week, so between May 27th and June 3rd, where we are today, there have been almost 100 more cases among healthcare workers. Professionally, what do we read into that? And is there anything that we can do to protect our healthcare workers in better ways that include more than just maybe PPE, i.e. why are healthcare workers seemingly contracting the virus at a higher rate than we see the positivity rate going down?
Thanks for that question, Megan. I wanted to just point out it's methodologically you can't look at an increase in one and compare that against the positivity rate going down. But I hear where your question is coming from, and the percentage of healthcare workers across the state who have tested positive is unfortunate. Healthcare workers are putting themselves on the front line every single day. Now, where Maine stacks up relative to other countries, or relative to other states, in terms of the percentage positive of healthcare workers, has us right on par with other states, which is to say about 1 in 5 cases. That number still remains incredibly high, and unacceptably so. One of the things that we are working on trying to understand better is what's the direction of transmission. Are healthcare workers being infected in the community and then potentially introducing it into their places of work? Or are they being infected in places of their work and then potentially bringing it back to their community? As with all difficult questions of that sort, what we know is that it's likely a mixture of both. So that underscores the importance of a few things. The first is that making sure not just the healthcare workers who may have patient contact are educated and trained on avoiding COVID-19, but also those who may more incidentally come into contact with patients. For example, environmental care workers. So one of the efforts that we've been undertaking more recently in partnership with healthcare organizations is making sure that all healthcare workers in a facility are up to speed on the latest infection control practices. This is also a key reason why we undertook the fit testing missions that I've discussed on numerous occasions. The more individual healthcare workers that can be fit tested means the more individual healthcare workers who can take advantage of N95 masks. Every piece of PPE is critical, but those N95 masks are really one of the most effective barriers to preventing COVID-19 infection among healthcare workers. And that is really, truly why those fit testing missions were undertaken. That was the motivation behind them, and that's why we're continuing them. I'd like to turn next to Joe from ABC 7.
Yes, Dr. Shah, thank you for taking the question. So throughout this whole process, we've had a lot of talk about PPE. And can you give us, I know you talked about it already, can you give us a little update on the length in which we have before that may become an issue again with resupplying? And do we have some sort of plan going forward with experts thinking along the lines of the virus maybe worsening in the fall and maybe in the works with getting, I know we're only in summer, but getting there in the future?
Well, Joe, you kind of said that there. You said, it's only in the summer, but one of the things that we've learned over the years in public health is that if we're not thinking months, years into advance, we're not thinking far enough. And so we are already beginning to analyze what the PPE demands may need to be or might look like, not just through the summer, but into the winter as we look at the potential for more or a different wave of COVID-19, as well as the concurrence of influenza. So right now, one of the things that we've been doing is taking a look at the average weekly utilization of PPE and using that as a basis on which to make projections about what PPE use might be, not just if COVID-19 were to persist, but if we were to layer on top of that something like influenza. Overall, the stocks of PPE across the state remain healthy, but that's healthy insofar as COVID-19 is concerned. If there were a major uptick in cases, for example, or if we were combating COVID-19 on top of a bad influenza season, we might get back into a position where PPE stocks became in jeopardy. Weeks ago, it seems like it was ages ago, but it was only a few weeks ago when during these meetings, we were talking about situations in which our PPE supplies may be exhausted. Thankfully, we're not there today. But if we've learned anything about an outbreak like COVID-19, an epidemic, a pandemic, it's that what we know today and the situation we're in today could be radically different a couple of days from now. So for that reason, we're starting our planning process, working with our colleagues at the CDC to start projecting what type of reserve of PPE that we need to have on hand now to make us prepared for any type of situation in the fall or the winter. I'm going to turn to Emily Tadlock at WABI.
Hi, Dr. Shah. So my question is, we have spoken with a parent from rural Penobscot County who says her daughter has Kawasaki disease. And they say it was hard for doctors to diagnose, so the treatment didn't happen right off. And while they are still waiting on tests to confirm she had COVID-19, her medical team at Boston Children's Hospital believe that was definitely the cause. So what can you tell us about the disease and the connection to coronavirus and what parents can look out for in their own children?
Great. Thanks for that question, Emily. To start with, at least as any, I would just want to be, there are no children in Maine right now who have been confirmed to have this Kawasaki-like illness. I understand based on what you've just told me, and I don't have any further information about the child that you just mentioned, but as it relates to children in Maine, there have not been any confirmed instances of this multi-system inflammatory condition, although we have made it a reportable condition and have continued to communicate with healthcare providers about it. So if a case were to be diagnosed in Maine, we would ask clinicians to report it to us. But here's what I would say to parents. The first is that it is a serious condition. The state of New York has recorded a fair number of cases of this type of condition. That being said, it's one that clinicians are now on alert for. Because there's been a high degree of attention drawn to it, because the healthcare community is aware of it, clinicians are now on alert so that if a child presents with the characteristic symptoms, they at least have on their minds the possibility that what they may be seeing in this child is that Kawasaki-like symptom. That's a good step forward for us in the public health community and in the clinical community. But here's what I would say directly to patients. Although this type of disease, this type of manifestation is exceedingly rare, it can be serious. This speaks to two things. The first is that now more than ever is the time to make sure you've still got that strong connection with your pediatrician or family practitioner. If you've been putting off those well child visits because you've been concerned about COVID-19, now is the best time to call your doctor's office and make sure your child is getting in for those well child visits. The second is that if your child's not feeling well and that you believe that they've got something more going on than just a cold, please make sure you reach out to your healthcare provider. Even though we are in a time of COVID-19 where so much around us has changed and so many businesses have had to be put on pause, preventive healthcare is not one of those things and should continue as it always has.
Can I just follow up with that? You mentioned,
Sure.
You did mention some of the symptoms and things, but what are those symptoms specifically for parents to be able to, because like I said before, it was hard for these doctors to diagnose it at first. So what should parents be looking out specifically in terms of this Kawasaki disease?
Absolutely. So the essence of this type of disease is extreme illness, and it's characterized by fatigue, by children just feeling like they've got roving body aches, muscle pains. And the essence of this Kawasaki disease is a particular type of rash. Now, children get a lot of different rashes, but the one that is characteristic of the Kawasaki illness is a pretty specific one. And it's one that we're all taught about in medical school, but it's not one that a lot of people see. So what I would recommend is that if your child was feeling ill a couple of weeks ago and then seems to have gotten better, but has now taken a turn for the worse again and is back to feeling extremely ill, and then they also have developed a rash of any sort, that is a sign to make sure you call your doctor's office.
Thank you.
You bet, Emily. I'm going to turn next over to Steve Missler.
Thanks for taking the question. I just, as you know, Dr. Shah, the president is going to come here on Friday and tour the swab factory in Guilford. And I'm wondering, and presumably he's going to talk about the federal government's response to the pandemic, and he's made some allusions to this in the past. I'm just looking for, I guess, if you could just give me a sense of what has it been like to interact, work with the federal partners, whether it's been at the CDC or elsewhere. Just in general, what are the good things? What are the bad things? As succinctly as you can.
Yep. So, Steve, we here at Maine CDC interact primarily with three federal agencies as part of our response. The first, most obviously, is the US CDC, and we are in touch with them in different ways, multiple times per day. I think it was yesterday evening or the 2 evenings ago, I had a call with Dr. Redfield, and so we are on multiple different times per day in closest contact with the US CDC. And I really do commend them for being available to us to answer questions, whether they are clinical or otherwise. We've always been able to get straight, direct, science-based answers from the US CDC. The other agency that we interact quite a lot with is a unit of the US Department of Health and Human Services called ASPR, the Assistant Secretary for Preparedness and Response. They are the organization that, for example, is overseeing the distribution of remdesivir. We've had frequent and multiple phone calls with them about remdesivir shipments, when they would be coming, what data that they've been seeing, et cetera. And I, too, want to commend ASPR for their quick and science-based work. When I've asked hard questions of them about remdesivir, if they didn't know the answers, they told me straight up and told me what they were going to do to find me the answers. And then lo and behold, they found me the answers. So I commend them for that work. We also work in close contact with FEMA. This is by and with our colleagues over at MEMA. And FEMA, of course, has been largely overseeing coordination and distribution of things like PPE. And similarly there, we've been delivered adequate amounts of PPE when we've put in specific requests for particular pieces that we've been running low on. We've gotten answers from them. I say all that because we recognize that we're in the midst of a pandemic. And so although there have been times in which we might have looked at things being done differently, we always give people on the other side the benefit of the doubt. They have difficult judgment calls to make in the same way that we've got difficult judgment calls to make. And one of the things that I try not to do in emergency situations is second guess individuals who might have more or different information than I do. These are incredibly difficult times with judgment calls that have to be made within split seconds. I try not to second guess those judgment calls, but rather recognize that they are under the same tremendous pressures that we are. And so from my perspective, working primarily with CDC and ASPR, I have a lot of respect for them and thank them for the quick work that they've been able to do. Steve, did you have a follow-up, or you often have a second question in your back pocket?
Yeah, I had a little bit of trouble with the mute button there. Sorry about that. I guess as it relates to testing, though, I know that there's been some struggles there, whether it's been getting reagents, et cetera. Has that been as smooth as you would have liked it?
Early on, again, back in March, as everyone is aware, the volume of testing reagents that we were receiving was not what any state wanted it. In fact, I think if you were to ask the US CDC, they would also tell you it wasn't what they wanted either. We recognize that there were some initial scientific challenges they had with the test, and then there was difficulty ramping up production. I appreciate that they had that challenge. I will tell you, Steve, from a testing or reagent availability standpoint, now that we have moved on to utilizing a test manufactured by our colleagues at IDEX, we have not had those challenges.
Thank you.
I'm going to turn next to Amy Brown at WERU.
Thank you, Dr. Shah. If I remember correctly, community transmission means there have been at least 10 cases in a county, and 25% or more of them have been among people who have not had known contact with someone else who's tested positive, nor have they traveled to a hotspot, right? So with Penobscot County, are they still on the community transmission list? And can a county ever come off that list if that number falls below 25%?
Okay, great question, Amy. So we've thought and we've talked a lot about this at length. And community transmission, you are correct as to your your recollection of our definition, that is exactly correct. And what community transmission essentially amounts to is an outbreak at over a large geographic area. And thus, we look at community transmission in the same way that we would look at an outbreak in a facility, which is to say, if we have gone 2 consecutive incubation periods without there being any new cases, we would then take a county off of a community transmission list. Now, that is a very high bar. That amounts to 28 days with no new cases. We fully recognize how high of a bar that is. But from an epidemiological perspective, that means we've gone not 1, but 2 full periods of transmission where there haven't been any cases. That gives us security in knowing that at least as to the community transmission piece, it's not out there. There might still be individuals in outbreak settings that could reoccur, but from a community transmission, sort of walking down the street style transmission, once a county has hit those 2 consecutive periods, that's when they would be taken off. We say that recognizing how high of a threshold that is, though.
So that's 28 days without any new cases that are associated with community transmission, not without any new cases at all.
It's actually 28 days associated with no new cases, period.
So an outbreak, which actually would potentially put the 25% much lower, could still keeps the county on the community transmission list.
And that is because outbreaks do not occur on islands within counties. Outbreaks occur in areas where people are coming in and going across the county, across multiple counties. And so even if an outbreak were to occur in a county, that would still mean necessarily that individuals could be entering or transiting through that facility and thus reintroduce it into the community. Yep, so
Sorry.
You bet.
May I ask a follow-up question?
Sure thing.
Is it known how long asymptomatic people are contagious, assuming they never become symptomatic and it's someone who just remains asymptomatic? How is it known when they are no longer contagious? Do they have to have another test or?
So an asymptomatic person can be contagious throughout their entire duration of illness. So someone who gets a test for COVID-19, tests positive and has absolutely no symptoms, they can continue to have absolutely no symptoms for 14 days. It's rare, I will tell you though, Amy, not many people are completely asymptomatic throughout the course of their illness. What we see much more often is not individuals who are asymptomatic, but rather individuals who are pre-symptomatic. We test them and they test positive a couple of days before they develop symptoms. But for that individual who remains completely asymptomatic throughout their 14-day period, they can transmit the virus to anybody during that time. It's actually 16 days. But what we really see is not so much true asymptomatic individuals. Most of the time it's pre-symptomatic people. And that's based on data from a lot of the outbreaks that have occurred on cruise ships, as well as data from outbreaks that have occurred in nursing homes. A lot of folks can test positive without feeling any symptoms on Monday, but a lot of them come Thursday or Friday will have developed symptoms.
Thank you.
You bet, Amy. The next question today goes to the Marquis de Don Kerrigan.
Thank you very much, Dr. Shah. Good afternoon. You're reaching on these. A question basically regarding PPE, and then another one regarding testing. As far as PPE goes, a viewer contacted us to ask about masks versus face shields. I know you've talked about this in the past, but does perhaps one offers protection in a different direction than the other, but is one inherently better than the other?
Don, could I clarify your question? Are you or your viewer, do you know if they're asking about N95 masks or the more typical surgical mask?
I suspect they're asking more of typical surgical masks that the public would wear, I believe.
Yep. So they're both very good. Face shields and surgical masks are both very good. And as with a lot of PPE, the efficacy depends on the integrity of the adherence to best use practices. So with the face shield, we recommend that it go pretty much all the way back almost toward your ears. With the surgical mask, it's got to go over your nose. I've seen a lot of folks wearing surgical masks on TV, but not over their nose. And it's got to be such that there's not a lot of slack out by the corners of your mouth, by the cheeks. If for either of those pieces of PPE, whether it's a face shield or a mask, provided they are worn in that fashion, they're both about equally good. For healthcare providers now, and I am only referring to healthcare providers here, if an N95 mask is not available, one of the recommendations we've made is for healthcare providers to wear both, a face shield coupled with a surgical mask. But for individuals out there, either is very good. Face shields, I think, have two benefits to them, which is that they can be reused for a much longer period of time. They can be wiped down very easily, and they really do provide that high degree of protection. And I should just, I say protection, and it's worth repeating or worth noting for everybody. The benefit of these types of PPE is to protect others around you. It's to protect your grandparents. It's to protect folks who might be immunocompromised if you happen to sneeze or cough or breathe. And so both a face shield or a face mask are both really good at doing that.
Thank you. The other question is about testing, and kind of follows up a brief discussion we had yesterday about this proposal that's being circulated to have to deal with the self-quarantine requirement and have people test out of state. But there's also part of that, though, also I believe assumes there would be testing available in state. It sounded like you said, talking about the positivity rate, that we may be testing enough. Is that correct? Or do you still believe we need a significant expansion of testing?
Good question, Don. I want to be really precise in my answer, but the answer to what I'm going to say is both. We need to be expanding along two different axes. The first is in our capacity to undertake more testing, and then in the amount of testing that's being done itself. Both of those are going to be necessary in order to get us to that 2% or so threshold mark that I'm really aiming for. I'd like to go even lower if possible, but we're working on two things simultaneously. Building out even more testing capacity, and then getting more and more and more folks tested or retested as the situation calls. So we still have more road ahead of us, but we are getting to where we need to be going. Even though that's still a ways off, we're definitely headed in that direction.
Is there an actual plan for step-by-step for achieving this?
Yes, we're not ready to roll out on the former, on the capacity piece. We're not quite ready to roll it out yet. The discussions are being held or are underway right now because we've got to make sure we can secure the equipment that can do the testing, that we can get the staff that would be needed, and then sort of to Steve Missler's earlier point about reagents, to make sure we can secure the reagents that we need. But we are under active discussions for all three. And then in parallel, working with healthcare providers and hospital systems. Although I'm very proud of the work that the Maine CDC lab has been able to do, I'm equally proud of the expansion of testing that's been happening at the hospital level. We're continuing to work with them to bring on more and more testing at the local hospital level. So for example, if someone needs to go in for a medical procedure, they can, the night before or the day before, visit that hospital, get their COVID-19 test, and be ready to go for their procedure the next morning. So we're working with hospitals to build out that capacity as well. That's on the capacity front. On the making sure more folks are tested front, Don, I think the most concrete step we've taken in that direction is lowering the point at which we would recommend universal testing from 3 to 1 in a congregate living or congregate care facility. That has greatly expanded the availability of testing that we will do at our state lab.
Thank you.
You bet, Don. I'm going to turn next to Caitlin Andrews at the BDN.
Good afternoon, Dr. Shah. I have a couple questions about the SARA's alert system. One, I want to get a better sense of, I guess, how does somebody access it? Like, can you only get through it through a provider, or is there a link on the website? And what is the trigger that you are hoping people use to log themselves? Is if they're confirmed positive, if they might be positive but haven't been able to get a test? Can you talk more about that?
Sure thing, Caitlin. So Sarah Alert is the IT backbone of our contact tracing work. And it's not so much something for the general public, but rather the way that someone becomes affiliated with Sarah Alert or enrolled in Sarah Alert is as follows. After someone tests positive for COVID-19, a disease investigator, a contact tracer, a Maine CDC staff member reaches out to that person, checks in with them, sees how they're doing. That then triggers the process of them enrolling in Sarah Alert. Someone can enroll, and that just happens during that conversation. It doesn't require anything more than the Maine CDC staff person to log their name into Sarah Alert and talk to that person about the way in which they would like to be communicated with. Some people like to be communicated with via phone, others by text message, others like to log into a website, and Sarah Alert can accommodate whatever means of communication is necessary. It doesn't require a cell phone. It can work by a landline, et cetera. So it's less of something that we're asking the general public to enroll in, but rather something that confirmed cases are enrolled in by Maine CDC.
Okay, so it's more of a device that helps you with the contact tracing you are already doing rather than an effort to get the public to buy in and voluntarily report if they think they might be sick or they may have come into contact with someone who might be sick.
You are correct. And it is the IT backbone for the contact tracing work that's already been in place. It's a great IT backbone, I should say. But it is not a new initiative as much as it is the informatics component that helps us check in with folks, make sure they're doing okay, and then allow us on our end to keep track of all of the data.
Thank you.
Okay. And the last question for the afternoon goes to Kevin Miller from the Press Herald.
Thanks, Dr. Shah. Can you hear me?
Yep, go ahead, Kevin.
Okay. So one specific question about a facility and then a more general question. Can you give us an update on the number of cases and deaths at the Cape Memory facility? I think yesterday you said there were 80 residents and then 23 staff members that had been tested positive. What are the latest numbers, and then how many cumulative deaths have there been there?
So Kevin, the number of individuals who have passed away remains at what it was yesterday, and the total number of cases is now 84. I believe that is, I'll get you the exact breakdown. I believe it's 60 residents and 24 staff members, but I'll make sure that the number that I've got is the most accurate and up to date. And then in terms of our ongoing work with Cape Memory Care, continuing with phone calls to make sure that they've got everything they need, be it from a PPE perspective, an infection control perspective, a retesting perspective. We're continuing to work very closely with them.
And how many deaths have there been there?
That was the same as yesterday. I believe that was. I'm going to double check, Kevin, to make sure. I believe again. I'll double check to make sure I don't give you the incorrect number.
Okay, great. I'll check with Robert as well.
Yep.
Then my more general question is about kind of following up on the discussion about community transmission. I know you talked about this in the past, but can you give us an update on what percentage of the cases that we're seeing in those community transmission counties are coming from community transmission versus someone getting it from a household contact? And then because we are seeing, as you talked about yesterday, some of these large gatherings in Cumberland County, in Androscoggin County, and in Penobscot County, I guess what are your thoughts about how things may look 10 days from now?
Kevin, we'll run the exact number or the more precise number with respect to percentage of cases in communities with community transmission that are community transmission. Boy, that's a lot of words. You said it a lot more elegantly than I did. So we'll get you the exact number of that. The last time I took a look at those numbers, it was the bulk of cases that were coming from community transmission. That was shortly after the cases at Cape Memory Care had stabilized. So it really is, as you can imagine, Kevin, given that thankfully our overall number of cases in Maine on a daily basis is low. A lot of that is driven on a day-to-day basis by whether there's a new outbreak. If there's a new big outbreak, then that number changes. And if there's not, the number is overall driven by community. We'll get you some more numbers on that to be sure, though. And in terms of your latter question, it's difficult to speculate about what we may see in 10 days. Certainly, I am hoping that, as I think I saw at length on news broadcasts, a lot of folks who were participating in the gatherings over the last few days, I saw a lot of folks wearing face coverings, and I thank everyone for that. I also saw a lot of folks who were spaced out where possible. I know that when you have a lot of people in a small space, it's difficult to space out. But as I always have asked, I truly do ask everyone who is venturing outside for any type of social communal gathering to please do everything you can to take care of your health, be it wearing a face covering or staying apart from one another. One of the things that we've learned that is particularly insidious about COVID-19 is this pre-symptomatic piece that we were talking about earlier, where folks can have it and still go visit their grandparents on the weekend, or visit somebody who may have just being recovered from surgery, or who may be immune compromised before they develop symptoms. And so I truly ask, in the spirit of community, if you're going to be out attending a mass gathering, please do everything you can to take care of not just your own health, but the health of others. And know that by putting on a face covering, you are doing both at the same time. You're keeping others around you safe. Indirectly, you're helping keep yourself safe. And you help keep people in your immediate family and community safe as well. Before we end today, I would like to again take a moment to thank the family of the individual who I commemorated and discussed earlier. There was so much more of a richly textured life that she lived that I couldn't talk about today because of just how many amazing stories that she had collected and amassed over her 100 years. And it made me realize that really, truly, one of life's gifts that we all have is being able to take the time to learn the amazing stories of the elders around us in our communities and the many textured lives that they themselves have lived. And so as we all go into the afternoon and the evening and think about where we are right now as a community and as a country, the one thing I ask everyone to do is to take a moment to talk to people in their communities. I say that because a question that I've received quite at length over the past several days is, what can we do about elderly members of our communities? How can we help them? And there's a lot of ways that we can help them from a prevention of COVID-19 perspective. But one of the things that I've been concerned about, we've all been concerned about, is an epidemic of loneliness that occurs within the pandemic of COVID-19. And for me, one of the ways that we can try to stem that epidemic of loneliness among the elderly is to do something as simple as calling them and listening to their stories. And I thank the family of this woman for sharing 100 years of stories of her life with us. But I also recognize that I've got people in my own family whose stories are just as incredible. So one of the things that I ask everyone to do, and that I am going to do, is to call up those elderly folks across the country that you know in order to help them share their stories with you. And I hope in so doing, hope that we can try to stem this epidemic of loneliness from occurring during this time of pandemic. So with that, everyone, thank you so much for taking some time to join us this afternoon. I very much appreciate it. I look forward to chatting tomorrow. Take care and have a good afternoon.